had finished a book, we're now looking for a publisher, about public health, but the subtitle of the book is Clear Thinking for Effective Action. So you can't really act in the world if you don't have clear ideas about what is it that you're operating on. And when we talk about improving health, improving the health of people, and then understanding how health systems are the vehicle for that, then we need to have a clear understanding. Now, there's a lot published here. That's the phrase I was mentioning, clear thinking for effective action. And I'm going to just give you a very brief overview. There's a lot being written here on this topic, and I don't want to make this a very academic exercise, but I think it's good to have those ideas, and then hopefully, as I said, if anyone has more interest in my experience, then in applying those ideas, I'm happy to do that. It is very rare, because we tend to have this division between the world of research and academia and the world of policy and action. It is very rare to have the opportunity, after you spend 25 years studying a topic, as I had on health systems, to be offered the opportunity to apply them in a real policy setting. And I feel incredibly blessed that I had that opportunity. And that, in turn, obviously allowed me to refine the way I think about health systems. And that's what I'm going to try to share with you. So let me just get started. Let's see. I don't know if I'm doing the right thing here to move the slides. I may need, there you go. Okay, good. Okay, so let me start just by the real starting point. When we talk of health in populations, which is what we do in public health, we talk about two fundamental objects of analysis or dimensions. One is, and this is a simplification, but it is a way of understanding complex realities, to try to come up with parsimonious frameworks like this one. When we talk about the health of populations, we are talking both of health conditions. Those are the diseases, risk factors, and other non-pathological conditions, like pregnancy, for example, as they are distributed in populations. And we study the frequency, determinants, distribution and determinants of health conditions. And then we study the organized social response, the way a society responds to deal with these conditions. And we can do that at the national level or at the global level. Now, those two levels are deeply intertwined. They are not, actually, I think, incorrect to call them different levels. Everything is local, simultaneously global and local. But for simplicity, two levels. And when we focus on one particular country and we study the health conditions, that is the national epidemiologic profile. You can characterize what are the main diseases and risk factors and other conditions in a national population. When we study the organized social response, that's the national health systems. The same things operate at the global level. But when we talk about global health is not foreign health. It's not what happens when we're in some other country, especially a poor country. Global health is about understanding the dynamics of interdependence as it affects health processes. And so when we try to understand health conditions globally, it's not just the aggregation of what happens in every country. It's the way that different parts of the globe interact in what could be called the global transfer of health risks. And just like there is an organized social response at the national level, there is one at the global level, and that's what you can call the global health system. I'm not going to talk about the first row here. A lot has been written about that. I'm going to focus on health systems. And I'm going to spend most of it on national health systems, but if we have time, we'll say a little bit about the global health system. So let's start with national health systems. And to articulate, before we articulate the fundamental ideas, we need to understand that, everyone talks about the health revolution of the 20th century, referring to the doubling of life expectancy that did happen during the 20th century. That's on the health conditions. But there was a parallel revolution, and that was the development of differentiated and specialized health systems. For most of human history, that social response was carried out by undifferentiated institutions like the family, like religious institutions. And although there were obviously doctors and hospitals before the 20th century, when organized health systems as specialized and specific entities to respond to health conditions, when they emerge, is really a 20th century phenomenon. In fact, really until the 20th century, hospitals were more places where people went to die. The idea of a hospital as a therapeutic space, as a space where you would actually seek to be cured or treated, is a fairly recent experience in human history. So what's happened in this parallel revolution, when you have this emergence of differentiated and specialized health systems, is an incredible set of changes. Now, because they happen slowly, we lose sight of them, but once you have enough time, they are pretty dramatic. It is, if you think of the economic significance, this is health systems, what we call health systems, and I will talk a little bit about what we call, is the largest sector of the largest economy in the world, the US economy, more than 18%, about 4.3 trillion invested in health or spent in health in the United States in 2021. But if you look globally, it's not just in the rich countries, health systems absorb about 11% of the world economy. And that's about $9 trillion around the world. Now, that's distributed with incredible inequalities. Expenditures per capita range from close to $15,000 per person to less than $50,000 per person in some of the poorest countries. So huge inequalities. But even in the poorest countries, it is a very significant part of the economy. It's a major source of employment. It has huge impact on the economic performance of a society. It has also become a major political issue. And in almost every country with democratic elections, health matters become a central part of the political agenda. And it has become a major arena for ethical deliberation, where we talk about some of the important ethical questions of our time. When does life begin and end? What is the basis for distributing? Is it, a commercial product, access to healthcare, or is it a human right? That is an ethical question. How do you think about it? And we are the arena for some of those fundamental ethical questions. Now, I developed, when I spent 2.5 years working at the World Health Organization under the leadership of Dr. Rob Brundtland, a truly inspirational leader, and with your colleague here at the Department of Global Health at the University of Washington, Chris Murray, who came with me, as well as many of the people who are now at the Institute for Health Metrics and Evaluation, we produced a framework and then an exercise where we ranked health systems in the world. I'm not going to talk about that. It was done once, and it created such a political backlash that WHO has never dared to do it again. Because, typically governments don't like to be evaluated and be accountable to the public. But in the framework, it's actually a very interesting exercise. We came up with 5 questions to understand health systems. And I'm just going to run through this. If you're interested, there is a paper published in the Bulletin of the WHO, and there's this World Health Report 2000, which before the pandemic was the most widely cited report in WHO history because it had the rankings. But few people read the conceptual part, and that's actually, I think, the more interesting. So the questions are fairly obvious. What is a health system? Which has to do with the boundaries and the actors and the relationships. What are health systems for? What are the goals of health systems? What is what you could call the architecture of a health system, by which I mean the functions that health systems perform? How good is a health system? Which means how well the functions relate to the goals. And then, very important, how can we relate that architecture to performance? This is sort of the holy grail, the science of health systems, if we're able to answer how a different configuration of the way we carry out the functions, the architecture, relates to different performance, to different goal attainment, we would have a science of health systems. We don't have that. But let me run, what we do know, however, the one empirical generalization we have is that countries with exactly the same income per capita, with exactly the same expenditures per capita on health vary widely in the performance of their health systems. Okay? So that we know. So there is something, and that's even after taking into account the effect of the non-health determinants, what's typically called the social determinants. Once you remove the effect of education and income and other proxies for those social determinants that Steve was talking about, you still have these wide variations. And so health systems matter because, and understanding health systems matter because even if you're a poor country, you can have a highly performing health system in terms of improving the health of the population. And even when you're a rich country, like the one we're in now, you can have a very poorly performing health system. This is not just about getting rich and then becoming healthy. It doesn't work like that. Getting into the details of health system matters. So let me run through this again. I'm trying to motivate you to read more about this rather than exhaust. So what is a health system? So the basic contribution, typically we have an administrative definition. Health system is what a country defines as a health system. That's not satisfying. Or we have a laundry list. We start listing. The health system is the Ministry of Health and the hospitals, and there's the primary care sector, and if you go into the United States, it has the VA, and you start doing a list of things. We should think of the health system like any system in terms of relationships. And to understand the relationships, we first need to understand the boundaries. What is in the health system? Instead of those conventional definitions of what's called the health sector, which is more an administrative definition, we propose that what was inside the health system was all those actions, we call them health actions, whose primary intent is to improve health, even if it's not administratively within the Department of Health. For example, providing clean water to communities in most countries is not within the purview of the Ministry of Health, but the primary intent of providing clean water is to improve health. It's not for recreational purposes. Regulations on street safety, on transit safety, wearing seatbelts, or the primary intent is to promote and protect health, to improve health. Therefore, those would be part of the health system. Now, that doesn't include the determinants of health. One of the effects of improving education is to improve health, but its primary intent is not to improve health. It is a determinant. It's not part of the health system. Okay, so that is the big distinction with primary intent. Now, instead of this laundry list, we need to understand interrelations. And the third big idea was that instead of just looking at institutions, which is the way we typically talk about health system, is the institutional side, the hospitals, the doctors, the nurses, the health centers, we need to think about the interrelation between institutions and populations. The population is not external. They're not the clients. They're not the patients. They are that, but they are part of the health system. People are part of the health system because they play 5 important roles. First, of course, there are patients with health needs that we need to deal with. But in addition, there are consumers with some expectations that you're going to be treated decently, that your intrinsic rights to privacy, for example, to confidentiality, are going to be respected. But people are also the financial source of the health system. Governments don't have money. It's people, whether organized in households or in other forms of organizations, who pay taxes, who pay premiums, or who pay out-of-pocket fees. They finance the health system. They are also citizens with very clear claims for rights and entitlements. That's why health systems are intrinsically political. And finally, and probably most importantly, people are co-producers of their own health. You don't actually produce health and give it to a person. It's like education. The user, the consumer, is also a co-producer of its own health. So that's all I'm going to say about what is those 3 ideas. It's primary intent, its interrelation. Health systems are the way in which populations and institutions, which have the primary intent of improving health, interact. What do they interact for? Well, that's the question of the goals. And in that framework, we recognize, of course, the first big goal of health system is about health. That's why that's part of the primary intent, right? Is to improve health. But it is not enough to improve the overall level of health in a country. You're also interested about the distribution. So it's not just about increasing the average level, but how is that distributed, which, as we will see, has to do with the concept of equity. However, we're not just only interested in health. Health systems are also about being responsive to the legitimate expectations of people. We could improve health by violating basic rights of people. These are, unfortunately, not hypothetical examples. In different epidemics, most recently with AIDS, many governments around the world locked HIV-positive people up. They limited their ability to move around. They did so proclaiming that would improve health, and probably did. I don't know how effective they are. I think there's doubt. But even if it was effective, that is in violation of a second goal, which is to respect the fundamental rights of people in the process of care. And like with level of health, you have both an average level of how people are treated, and a distribution. So, typically poor people, women, indigenous people have less responsive health systems than other people in the population. And finally, a third goal is to have fair financing. You could have a system that's very good at improving health, very responsive to the legitimate expectations of the population, but places all the burden of paying for the health system on the sickest. That's what a fee-for-service system achieves. It makes the sickest pay the most. The reason why all advanced health systems figure out a way in which you separate the moment of financing from the moment of using health services is so that you can have a rule of fair financing. The rule of fair financing is that people contribute in proportion to their economic means and receive services in proportion to their health needs. Fee-for-service is the other way around. People contribute according to their health needs, the sickest pay the most, and receive according to their financial needs. If they don't have money, they don't get access. So fair financing is another goal. This is very important when we assess, as we did in 2000 in the rankings, we didn't only measure how well health systems were in improving health, but also we had an index of responsiveness, and you can read all about it. It was very controversial from a methodological point of view, but we included fair financing. So the United States was ranked like 36, and people were very upset here. And we have very good hospitals, yeah, sure. Except at that point, there were 40 million people without insurance in the United States, and the levels of catastrophic expenditures by American families was the highest among rich countries. So they were penalized on fair financing, and that's what dropped the ratings. And that caught the attention of some politicians who didn't like to be in number 36 when they thought that they were number one. Then, just to be clear with the concepts, how well you achieve health and responsiveness gives you the quality. Because quality is not just about improving health, it's also about the interpersonal dimension of quality, treating people decently and with respect to their rights. The distribution is about the equity, and then when you relate those two to the way it's financed, then you have the efficiency of a health system, when you can achieve maximum levels of health and responsiveness with fair financing and an efficient use of that finance. So, if we're going to achieve those goals, what are the functions that a health system needs to perform? And in that framework, typically we think of the core function as the delivery of services. The health systems are there to deliver health services. That's true. And that is the core function. But first of all, provision or delivery It's not just about personal health services, it also includes non-personal health services, what we typically call public health services, like epidemiologic surveillance and other public goods associated with health. And secondly, to achieve that core function of provision or delivery, there are a number of supporting functions. The first one is the function of financing, which has to do with the way you collect revenue, the way you pull that revenue in funds, and the reason of using tax-based or broad national health insurance is so that you can pool the different risks of people, and then the way you spend the funds. And again, I'm not going to go into the details, but there is a function of financing, and countries vary substantially along that. And then all of that is supported by a key function which we call stewardship. Others have called it leadership or governance. It's the same idea. There are functions which are typically carried out by government of setting rules. Regulation is part of stewardship, but it goes way beyond regulation. It includes something Steve was saying, which is in the Alma Ata Declaration and the philosophy of primary care, which is what we would call intersectoral advocacy. It's promoting interventions in other sectors that improve health. So when I was Minister of Health, I lobbied the Minister of Finance to raise the taxes on tobacco. I had that raising taxes is not a function of the health minister, thank God. Otherwise, we would be very unpopular. But the function of persuading the finance minister to do so with a health code, which was to discourage, especially young people, from starting to smoke, from becoming addicted to nicotine, that is part of stewardship. That is this idea of intersectoral advocacy. And then finally, there's a fourth function called resource generation, what universities do: educate the workforce that works there, do the research and create knowledge as a resource. Information is a resource, obviously facilities and technology and equipment. And there are a number of institutions that carry out that function, like universities or the pharmaceutical companies or whatever, carry out those functions. So those are the four key functions: a core function of providing care, both personal and non-personal services, but those supportive functions, including this stewardship function. So how good is then a health system? And again, I'm just going to mention the big idea. We talk about the performance as if it was an absolute. So we compare Switzerland with Swaziland. And we say, Switzerland has a better health system because the life expectancy is higher in Switzerland. Well, that's the wrong way of thinking about performance. Performance is a relative concept. And the relationship is again captured here in a very simplified way: financial resources, human resources, other resources. And here's a hypothetical graph just to show. You can have country B, which, if you just measure absolute attainment, would be doing better than A. But when you relate that to the health system resources, you have a minimum possible, as even if you have a lousy health system. If you put more resources, you should be doing slightly better. And you have a maximum attainable, which is what the state of science and technology allows you to attain. There are diseases that cannot be cured. That's not a problem of the health system performance. That's a problem of expanding through research and innovation the frontier of what's possible. But when you make this relative to the amount of resources invested, A has actually a better performance, because performance is then measured as the gap between what's attainable or achievable and what's actually achieved. If you put more resources, you should be closer to the maximum, which is not the case with B. And that's how the United States has a poor performance. It invests incredible amounts of resources, more than 18% of GDP, and it actually has lower life expectancy, higher mortality, maternal mortality rate. And then, the last question is, why is that? And I'm not going to but how do we relate this difference in performance to the way the functions are structured? And we have known in the science, we We still have a lot of research to do, but we know some things about that. We know that financing should be mostly public. Private schemes of financing out of pocket don't work. This is not an ideological assertion. This is based on good theory and empirical evidence. Private insurance is affected by huge market failures in the insurance market. It doesn't work. The best health systems have public financing in a way that separates the moment of use from the moment of paying for it. The worst health systems are the opposite. People are paying out of pocket. Secondly, we know that strong stewardship is important, including the capacity to then act on the social determinants. Stewardship involves a strategic vision that, for example, would prioritize upstream interventions to stop people from getting sick in the first place. That typically involves exercising that part of stewardship that I was explaining before of intersectoral advocacy. Making improved health not just one of the goals of the health system, but making that a society, a government-wide or society-wide goal to be achieved by mobilizing other sectors, like improving the education of girls, like improving, reducing levels of poverty, like expanding decent housing and working conditions. All of those social determinants, although in themselves are not part of the health system, advocating to mobilize that and creating the policy for it, where you can actually do that, as we did in Mexico, that is part of stewardship. And then finally, we do know that a delivery system that has a strong basis in primary care is a very important one. So I will summarize that by saying that with this one graph, and again, this is the whole science of health systems, but when you look at the functions, there's always one of the big policy debates is how much should be public and how much should be private. Every health system in the world has a public-private mix. Even systems that declare to be public have some element of private, and conversely. People think of the United States as a mostly private system. Well, it's not true. Most of the financing is actually public through Medicare and Medicaid, through the VA. It has even public provision in the VA or the Indian Health Service. So every country has a mix. And what we have learned is that stewardship is the quintessential public function. It requires strong presence of governments with transparent, non-corrupt procedures to regulate and provide strategic guidance. Financing, as I said, is mostly a public function. Service provision can be pluralistic. It actually, and research generation is typically more a private function because particularly the technological piece is typically located in private companies, in the private sector. We tend to think that the provision is what defines whether a system is preponderantly public or private, but it's actually the way stewardship and financing are carried out. For example, when we talk about the UK system, we think it's mostly a public system. But in the UK, GPs, the primary care part, is actually carried out by independent contractors of the National Health Service. They are not employees. They are independent contractors. So they are private providers, but why do we call it public? Because the financing is public and because there's clear rules. You cannot just do or overprescribe. There are rules, and the financing through capitation is such that encourages behaviors, and there's rewards from the payer, which is the government, to operate on prevention and to emphasize preventive measures. In Canada, which we also think of as a public system, most hospitals, again, are not governmental hospitals. They're private non-profit entities. It is public because the financing is public and because there's clear stewardship. So those are some of the lessons we have learned from around the world. Let me just say one word, because I am keen and I do have to catch a plane, so I'm going to have to leave at 4:45, but which is how we have scheduled. I will just mention that we do have an increasingly pluralistic global health system, WHO, it's here in the center, and this is taken from a paper by anyone who's interested that I wrote with my colleague Swery Moon called Governance Challenges in Global Health. It appeared in the New England Journal of Medicine in 2013. But basically what you have now is a number of other entities. These are the countries, because countries are part of the global health system. Okay, they are member states of the World Health Assembly, they are donor countries. And then you now have bilaterals, you have hybrid institutions like the Global Fund. This has been a 21st century phenomenon. The explosion of entities active in the global health system has happened pretty much with the Millennium Development Goals in the year 2000. And it's incredible, but the Gates Foundation did not exist until 2002 or 3, when it was started. The Global Fund was also created in 2002. Gavi, just a few years before, 1998, there was that which we call the golden era of global health. Like in national health systems, there are other parts of the global or international system that we need to interact with because they are determinants of health. And these are not part of the global health system, but mobilizing them, which is what these little bridges attempt to portray, that is a function of the global health system. To make sure that security issues and conflict resolution and peacekeeping, which is a big source of deaths and disability and injury, are kept under control. To make sure that in the environment that we deal with climate change, which has huge health implications, or in migration, or in agriculture, and all its implications for food security, and therefore nutrition, and therefore health. Managing the rest of those other arenas, global arenas, is part of the functions of the health system, which also has a stewardship function. And I'm just going to mention them. This is all explained in that article. But 4 big functions. They are similar but different than the ones I mentioned for the national health systems. In the production of public goods, research and development is the ultimate public good, global public good. Standards and guidelines, the international classification of disease, which is not the most glamorous part of global health, is a critical public good. We wouldn't be able to do anything if we didn't have an international classification of disease. Both those standards can be used for national use and also to regulate international transactions. We saw it in the pandemic. You need a WHO certification of vaccines so that they could be distributed globally. That's a global public good. Comparative evidence so that we can learn from each other's experience. That's a knowledge-related global public good. The second is the management of externalities. We just saw it with the pandemic, right? Actions that happen in one country that affect the rest of the world. And that's why surveillance, epidemiologic surveillance, and information sharing, as well as preparedness and response, those are core functions of the global health system. They are being debated today through the pandemic treaty that's being discussed. It is one of the core functions. Then we have what I call mobilization of global solidarity. We tend to focus on this, and it is very important. It's development financing, it's technical cooperation, it is humanitarian assistance, that means in acute emergencies, and then it's serving as an agency for the dispossessed, protecting populations when their own governments, by the international community, populations that are subject to the human rights violations by their own governments. And I encompass that under this function of mobilizing global solidarity. And finally, stewardship, which is similar at the national level, but globally, because we don't have a global government, it doesn't have acts of authority. It's more about convening for consensus building. The Alma Ata is a beautiful example. In the middle of the Cold War, every country in the world agreed on some basic principles around primary care, priority setting, rule setting, having clear rules about, like the certification of vaccines I was mentioning, evaluation for mutual accountability. That's why we did that performance assessment in 2000. Countries don't like it. Not countries, governments don't like it, especially when they don't do very well. But that is a function of the global health system. What I mentioned, cross-sectoral health advocacy, those are the key components. So let me stop here, leaving a good few minutes for for discussion. I'm happy to talk about this, but if you prefer to go to the practical case of how, especially the national health system framework was applied in Mexico, I'm also happy to address that. Thank you very much.
Thanks very much. So I'll present them so people don't talk too long. The first question, maybe a personal question, what inspired you to create Seguro Popular? And how do we know when health reform is necessary and when it's not? Sort of political question or agenda setting question. And how do we know how much to change and where to focus our limited resources, particularly, I guess, in the good policy side?
So, you'll have to invite me to give another lecture on Seguro. I could spend the next few hours talking about that. Seguro Popular is, for those who don't, in Spanish, it literally means people's health insurance. And it derived from a very solid philosophy of benefit. First of all, understanding that in Mexico, like in many other countries, there was a fundamental divide because health insurance began around the world associated with employment. That's how European health insurance started. Countries in Europe and other countries, Canada and the US, rich countries typically, quickly made it universal and decoupled salary employment from access to insurance. But many countries did not. The United States was one of those. Obamacare was an attempt exactly to decouple employment-based insurance and give insurance to people who are self-employed or unemployed or out of the labor force. So Mexico had the same situation. By the way, Chile had a similar health reform. It was employment-based, and it had the largest expansion of coverage in human history by doing that decoupling. This is what we did in Mexico, like many countries. About in the year 2000, there were 100 million people there, and about half of them had insurance by virtue of their employment. It was social insurance, social security is called. But the other half did not have insurance. And those were the self-employed, the unemployed, and people out of the labor market because they were full-time homemakers or full-time students. They were not in the labor market. That was half of the population. It happened to be the poorest half, because the largest group there were peasants who cultivate their own land. They didn't have an employer, they didn't have insurance. And we did the first ever calculation of what's called national health economics, and demonstrated that contrary to common preconceptions, at that point already paying out of pocket was the main form of funding. And we quantified that there were about 4 million households every year that became impoverished because of paying for health care. These were mostly poor people. So that was the inspiration, the evidence that the main driver of inequality was that segmentation of access. Even though the Constitution said that access to health care was a right of people, in practice, only half of the population had a way of exercising the right, and the other did not have that. It's not enough to recognize that right to create instruments so that people can actually exercise. And so what we did was create a public insurance scheme for that half, and try to get as close to the level of benefits and close the gap. And the meant that were closed. This is probably the single most broadly evaluated, because it comes from the world of research and leading evidence. So we wrote into the law the obligation to evaluate it, but it's also generated a lot of academic interest. So there's a literature at last count of about 150 papers in peer-reviewed journals about Seguro Popular, and I know you cover it in your course, so there's a wide literature. And that's how we know that it actually did reduce dramatically the level of catastrophic expenditures, close some of the gaps with people who had insurance, and it had a lot of things that needed to be improved. It was not perfect, but it did achieve some of its stated goals. So that was the inspiration.
Very good. Another question. As health minister, how do you fight political corruption and state capture by capitalists, I guess, to provide services for the underserved?
Well, corruption is a huge issue around the world. With Seguro Popular, we wrote into the law. The first one was the health system was under financed, and we wrote a formula so that the budget for health to fund the local blood to not just the neurological program, but it actually goes back by 10 years. The allocation to the Ministry of Health, the Department of Health, moved to local blood, grew fourfold after accounting for inflation between 2000 and 2015. A fourfold growth. There was no other part of government that really so much as health allocation. You know, we were very conscious. It was not, it's corruption. If you don't have money, no one steals it. So you have a funded system, there's very little corruption. If you start investing, you need to be very careful about that. And we introduced a number of very rigorous measures to prevent that corruption. You do it through system design, not through exploitation. And again, there's a lot written on the specific steps that we're taking to try to prevent corruption. And there were a few cases that like everything in public health, we try to prevent, and then when cases happen, we need to prosecute. So like government of the state was the local jail, there's taking the money that was all used for other purposes. And so it was a very clear strategy to deal with corruption. Then on the regulatory function, people don't realize that ministries of health are a big part of regulation, and that's where a lot of money is involved. If you are regulating the pharmaceutical industry, it's very easy to create. So we created a brand new agency called the Federal Commission for Protection Against Health Risks. That was a sort of FDA plus EPA, very large. And I recruited the anti-corruption side to the initial commission. So that it was good, because that was actually a much larger source of corruption than almost anything else. So it's got to be a deliberate, intentional, deliberate system design to make sure that you don't have the unintentional effect by doing good things, like including the allocation of resources to help. You don't give rise to unintended consequences like more acts of corruption.
This person wants to take us to the global health system by asking, in brief, what's your opinion of the pandemic treaty, how it's going, how it started, how it's going? How do you feel that such a treaty should interact with national health systems to make sure they don't break down during future pandemics?
So, I've been very close to WHO for all my career. And then I did work inside the beast for a few years. We talk of WHO as the secretariat. The WHO is the member states. The World Health Organization is an organization of member states, actually, who join voluntarily. And then we elect a secretariat, which is the head of the administration of bureaucracy that runs the institution. But when we talk about WHO, we criticize WHO, we talk about the secretariat. I am not going to defend the secretariat or the recruitment, but in my observation, the main role of WHO is an instigator of member states. In failing to comply, because they argue that they are sovereign entities. And I do think the pandemic has lots of examples. We may notifying about the outcome. Even though it's an obligation in the international health regulations, that costs millions of deaths, literally. The position of bans and the counterproductive things like you isolate a new variant in South Africa, and suddenly you blockade basically South Africa or India. And those were actions that were taken against the recommendations of the WHO. So it's the behavior of national governments that is the big problem. Again, not denying that we need to improve and reform the administration, the secretariat. But if we don't tackle that, the treaty will be a failure. We need to create two things. One, we need to do the international health regulations, but they're pretty good. The problem is there's no enforcement mechanism. There's no enforcement. We need to create an enforcement mechanism, as we have in other areas. The sovereignty argument doesn't apply because we have an atomic energy agency that actually has enforcement. We even have a World Trade Organization that has enforcement. Why have we not developed enforcement mechanisms for the World Health Organization? And the second, we need to have a system that's ready to enforcement of sanctions, but also of protections to induce countries to behave correctly. There's a very strong negative motivation for countries to declare and notify about an outbreak because they immediately suffer the consequences, the economic consequences of that. So there's been a proposal to create an insurance mechanism. So we need, those are the two litmus tests. If WHO is the organization, if the countries are enlightened enough to realize that it's in their collective action, in their collective interest to act collectively in the face of common threats and to create regulations that actually produce both positive incentives to comply with the regulations that protect everyone and negative incentives, sanctions that penalize those that don't comply. I would prefer more emphasis on positive inducements, but that's going to be, right now, you have great international health regulations, always available to improvement, but totally toothless and without any enforcement capacity, then it's an impossible job for the secretary to then enforce those regulations.
Last question. I'm actually going to riff a little bit on one someone else said. So it seems like a big challenge is to convince governments that health is a human right. But in doing so, we also create a problem because there's finite resources and more claims to resources that are available. How do we thread that needle? A lot of American experience has been challenging in that regard. How do you think about getting through that tricky ethical situation?
Yeah, the first question actually, I didn't answer the question of priority setting. Yeah, I mean, there's been 4 basic principles to allocate, to regulate or determine access to healthcare. See health as a merchandise, just like you buy cars, and some people have Mercedes, and other people have bicycles. Well, you accept that people have a health system. Almost no country accepts that, although for a lot of history that was the actual principle. You can see access to health as an act of charity, either public charity, beginnings of health systems. We thought about systems for the poor, providing care for the poor. There were institutions exclusively targeted to the poor. Again, that was superseding that. You can see it as a social privilege. That's how social insurance started. The industrial workers, the military, the bureaucrats, they all have social insurance. The most enlightened way is to think about healthcare as a human right. And I think most countries now have adopted that as a declarative statement. The key is once you do that, you need to translate that right into actionable entitlements, and you need to create a financial and organizational mechanism. You need to design the health system around a human rights framework. Now, I use that, which is mostly an ethical deliberation, to persuade the Congress these rules that have to be voted at a time, like in most parliaments. There were different parties, there were 4 parties. And I remember when I came to the evidence, showing that the allocation of federal funds to health on a per capita basis was about 3 times higher for people who had a salary job and therefore social insurance than for people who were on insurance. So I asked a Congress person. So, in your allocation behavior, you are telling me that the value of a human life is a function of the work you can carry out, or the effort of the person. No, of course not. Every human life is valued the same. You say, good, I'm glad you said that. You need to change your allocation there. Because right now what you're doing is you are saying you're putting 3 times more money, it means you value that 3 times more. And that was the single the most important discussion I had, when I brought them to confront the contradiction between what they were doing in allocating the budget and what they were stating as their ethical framework and what the Constitution said. It said it's a universal. They were actually violating the Constitution of the country. So, once we won that battle, we created a mechanism. And that's why allocation, to look at that, made the whole allocation of district health grow fourfold after adjusting for inflation in that 15-year period. So that's what you need to do. Then the question is, even in increased money, you do not have money to do everything that's medically necessary. Very many health systems do a lot of medically unnecessary procedures. I'm not even talking about medically necessary procedures, not even the richest health system can do everything. You need to have every health system sets priorities. And the question is, are they explicit or implicit? Because no health system can provide everything for everyone. You need to have a transparent, evidence-based process and ethically driven process to do that. And the law that created to do that, especially when it came to high costs, created a separate fund for prevention, protection against catastrophic expenditure, which funded access to high specialty care. And we created a very transparent mechanism, the law that priorities would be set based on the size of the burden of disease, the cost effectiveness of available interventions. You could have something that has a very high burden, but you don't have it, you have to get oriented for research, but not for care. So the cost effectiveness, and then we added social acceptability to have and then we created a deliberative body and a mechanism where as more funds got available, the list of priorities grew. And that based on what Julio's health economists call that progressive universalism. That's what I'm going to do. And the idea of progressive is that you increase access progressively, but you do that starting by the poorest. And the law said that the coverage of the single program would start with rural, poor, and indigenous communities. And so when new technology became available, for example, in the form of human papillomavirus vaccine, I think it's one of the few cases where the vaccine was first generated, it was funded publicly for poor people, and then eventually it grew. So that idea of progressive universalism was the way we tried to address the most politically complicated question, which is the question of priority.
Well, let's give Dr. Frenk a hand.